So welcome everyone. And we are now into the fourth of the series in MUS UCAM webinar, teaching webinars. And I am absolutely thrilled the kind of response we are getting. So that makes me sure that we're all gaining out of it, whether it's the delegates who are joining us, the UCAM graduates, and even the faculty. It gives us an opportunity to keep refreshing. And today's speaker, we're having Dr. JEENA Bordoloi. I don't think that she's a new name to any one of us. She has done MUS so proud, nationally as well as internationally. It is entirely her efforts, her perseverance, and her passion in musculoskeletal ultrasound, which makes me believe that she is one of the people who will inspire a lot of future generation of musculoskeletal ultrasonologists. So thank you, JEENA, for doing this all, giving us this opportunity to thank you for so many publications, international publications. And today what JEENA is presenting is one of her, again, international papers that was submitted last year. And it was submitted in Healthcare, which is one of the leading international journals from Switzerland, Impact Factor 3, which is really an important impact factor, good impact factor. So JEENA, on to you, and we await your presentation. Okay. Go on. Thank you.
Ma'am, is my presentation visible? Is my presentation visible?
Not yet, JEENA.
Okay. Wait a minute. Yeah. Okay.
Yep. Absolutely. Okay. And we can hear you loud and clear.
Okay, ma'am. Just a moment. Okay. Good evening, everyone. And thank you, Nidhi, ma'am, for that very kind introduction. And I'm truly honored because it has always been you and teachers like Dr. Fernando and Dr. Mohit Bipan sir and everyone who has really inspired me to publish my work. So thank you so much. So today I shall be talking on high resolution ultrasound of nerve tumors, PNSTS, that is peripheral nerve sheath tumors, and a few cases beyond that. So nerve tumors, their presence has been documented in history since maybe 1500 BC in the Ebers papyrus, and then they have been documented as lumps and bumps in the coins of the Parthian kings. Then the Quasimodo in the Hunchback of Notre Dame was also thought to have neurofibromatosis, then also has been documented in Inca mummies. And then there's the famous elephant man in the 19th century, and who was described to have neurofibromatosis by von Recklinghausen, but later on in 1986, it was written in the British Journal of Medicine that he was rather suffering from Proteus syndrome. And in the modern day scenario, we have many neurocutaneous syndromes like, these pictures of Indian men, which I've just gathered from the net. But then nerve tumors are not just about neurocutaneous syndromes or these very grotesque looking tumors, but then with the advancement of medical science, as well as imaging and genetics, as well as pathology, nowadays there are a variety of tumors which are found to be of nerve origin, and also some having non-neural elements which are found within the nerves. So when we say peripheral nerve tumors, they are a heterogeneous group of mostly benign tumors that arise from the nerves extending beyond the brain and the spinal cord. So a quick brief about the normal anatomy of the nerve. We know that a nerve is composed of bundles of fascicles, which in turn is again made up of bundles of axons. So the nerve as a whole is surrounded by a connective tissue sheath, which is known as epineurium, and the fascicles are surrounded by perineurium, and each axon is surrounded by endoneurium. So the axon is a part of the neuron, which is the basic unit of the nerve, and each neuron is composed of a cell body, which has a nucleus, and then there are outpouchings called dendrites. And the axon is this long filamentous structure arising out from the cell body. And the distal end is known as the axon terminals. And each of these axons in the peripheral nerve are covered with myelin sheaths, which are formed by Schwann cells. And, there is a gap in between the Schwann cells, which are known as the nodes of Ranvier. And it is these axons which are responsible for the conduction of nerve impulses. So regarding classification of nerve tumors, there have been many classifications, but it was the first time in 2013 that nerve tumors, that is only the nerve sheath tumors, were included in the WHO classification of the soft tissue tumors. And they were an exception because they arose from the nerve tumors arise from the neuroectoderm, whereas the rest are mesodermal in origin. And most arise from the classic peripheral nervous system elements, that is the Schwann cells and the perineural cells. So nerve sheath tumors represent about 10 to 12% of all soft tissue neoplasms. And out of them, the neurofibromas and the schwannomas are the most common benign PNSTs. So again, in 2020, the WHO classification was updated. And so we have these varieties of peripheral nerve sheath tumors, that is schwannomas, neurofibromas, plexiform neurofibromas, perineuromas, a granular cell tumor, nerve sheath myxoma, solitary circumscribed neuromas, meningiomas, hybrid nerve sheath tumors. And the main hallmark of this new WHO revision is the inclusion of multiple novel genetic alterations and the surrogate immunohistochemical markers for the various entities. But for all practical purposes, I have used this classification, which has been given in Bianchi and Martinoli's textbooks, that nerve tumors can be neural or non-neural in origin. So the neural tumors are basically the peripheral nerve sheath tumors, that is the schwannomas and the neurofibromas, and the malignant peripheral nerve sheath tumors, and also the non-neoplastic, that is the traumatic neuromas. The tumors of non-neural origin are intraneural hemangiomas, fibrolipomatous hematomas, and intraneural ganglia. So the PNSTs can be classified into benign and malignant. Benign constitute 12% of all soft tissue neoplasms, and they are essentially the schwannomas and the neurofibromas. And because schwannomas arise from the Schwann cells, whereas neurofibromas arise not only from the Schwann cells, but also additional cells like the cells of the epineurum and the perineurum and the connective tissue cells like the fibroblasts and the mast cells, etc. But malignant PNSTs is a general term which is used to describe malignant entities of both the above types, as the cell of origin is often unknown. So neurofibromas are further classified into the localized variety, which is seen to arise from cutaneous nerves, the diffuse varieties, which arise from the nerves in the subcutaneous tissue of the head and neck, and the plexiform variety, which involve long nerve segments, and they are seen as enlarged and tortuous nerves like a bag of worms. So the PNSTs can affect any peripheral nerve. The most common is in the intermuscular location, which is followed by subcutaneous and then intramuscular. They can affect any age group, but it is most commonly seen in the young age group, that is between 20 to 30 years, and they are uncommon in children, and the incidence is about 1 per 1 lakh people per year. The clinical presentation, yes, we can sometimes see a mass, and which can be symptomatic, painful, or sometimes they may be asymptomatic. There might be sensory alterations like paresthesias, hyper and hyperalgesia or allodynia. There might be pain and weakness, there might be muscle atrophy, and often there are neurocutaneous stigmata when they are associated with the different syndromes like the neurofibromatosis. So, but today our talk is basically going to focus on imaging, that is the ultrasound imaging. And I have used my talk based on these 3 very important papers by John Jacobson and also by Alberto Tagliaffo, and also a very recent one by Lefebvre. So we know that in imaging now, both MRI and ultrasound are very important imaging modalities, but then we always have to start with the why. That why are we imaging nerve tumors and why is it so important? So When we image, we have to assess the type and the nature of the lesion. We have to look for predictive signs and biomarkers to assess whether the lesion is benign or malignant, to assess the disease burden and the extent. That is, look at the number of lesions, the size of the lesions, and the extent of the lesions, to assess for any potential complications, or to look for any associations and syndromes, any associated malignancies, and also to help with post-treatment assessments. So as we know, the main advantages of ultrasound in nerve imaging compared to MRI is that, of course, it's low cost, non-invasive. We have the ability, it gives the ability to explore large segments of nerve trunks, helps us to examine nerves in static and dynamic study, and importantly, they have a very much higher spatial resolution, especially within 5 centimeters from the skin surface in case of very superficial tumors compared to MRI. So also the other points to remember while we are doing an ultrasound is that we've got to choose the transducer well, especially in superficial tumors. Try to go for a very high frequency transducers. And of course, for deeper tumors, especially in the popliteal fossa, go for lower frequency ones. It's very important to know the topographic anatomy and the landmarks to identify the nerves from which that particular lesion is arising. Always scan the nerve in the long and the short axis, look for any change in the dimension. And in the short axis, we are basically looking at the anatomical location, the caliber of the nerves and the architecture of the nerve. But in the long axis, whenever we see an abnormality, it helps us to look at the extent of the pathology much better. And of course, there is sonopalpation, that is the Tinel sign, that is when we apply pressure with the transducer, it elicits the same kind of symptoms like the pain or periesthesias or allodynia, which the patient might complain of. So we know that on ultrasound, a normal appearance of a nerve due to its bundle of fascicles is honeycomb or end-on brush on a short axis, and it gives a bundle of straw in a long axis. We usually do not detect blood flow within a nerve, even on power Doppler in a normal nerve, and a nerve never demonstrates anisotropic properties. So whenever we come across a soft tissue tumor, there has been this statement from the radiologists, Society of Radiologists in ultrasound, and there is a consensus statement which was led by John Jacobson. And there's another, paper showing guidelines for soft tissue tumors in adults in ESSR. And for that, they say that, whenever we come across the location in the body, the location in tissues, the composition, whether it's solid, cystic, entirely cystic, the size in craniocaudal, anterior, posterior, the involved structure, sound attenuation, the echogenicity, the margins, whether it is smooth, ill-defined, lobulated, irregular, infiltrative, look at the vascularity, the Doppler mode, and also other features. So even when we look at a tumor, we've got to look at these points and describe the tumor. So now finally coming to the nerve sheath tumors, which have been described in literature, and especially in these papers, which were published in recent times. So it has been said that there is a considerable overlap between the ultrasound features of and schwannomas, and sometimes when we really cannot differentiate between them, they are usually homogeneous and hypoechoic in 67% cases, but they may be heterogeneous, which is considered to be an atypical finding. Posterior acoustic enhancement is seen in 75% of cases. But then the nerve in continuity with the presence of an entering and an exiting nerve from a mass, also known as the tail sign, is the most important and pathognomonic sign that a tumor has its origin from a nerve. So whenever we see a tumor and we see this entering and this exiting nerve, we are sure that it is a nerve tumor. So it is usually seen as a well-defined hypoechoic mass, which can be fusiform or round with a hyperechoic capsule oriented along the long axis of a nerve. But this is mostly seen in only 90% of cases, and it might not be seen in very small tumors. It's important to document a location in relation to the nerve. So it has been found that the schwannomas are eccentrically located and the neurofibromas are centrally located within the nerve. And as I mentioned before, that the tail sign, that is finding an entering or an exiting nerve, may not be visible in very small nerves, especially small peripheral nerve branches. Now, this was a case of a 16-year-old girl who was, had all the symptoms of a nerve tumor in her anterior leg, and the Tinel sign was positive. But when I scanned the patient, I saw that there was this oval hypoechoic tumor, but I really couldn't demonstrate entering and an exiting nerve. But then also what I noticed, perhaps for the first time in an peripheral nerve sheath tumor, a suspected peripheral nerve sheath tumor, was the presence of this hyperechoic fat in the superior and the inferior poles. There was vascularity in this tumor, and I just gave a provisional diagnosis of a peripheral nerve sheath tumor because I really couldn't demonstrate the entering and the exiting nerves. But then review of literature later, I came
Can
to,
can I
I found
interrupt
out.
you, Jeena? Can I
Yes,
interrupt you?
yes,
Can you
ma'am.
take a marker? I don't think, yeah, now it's your marker is moving. Yeah,
Okay. Okay,
yeah.
thank
Now,
you, ma'am. I'm
could you
sorry. I was
start
so
with
nervous. Maybe,
yeah, the
I should
split
have
fat
just, yeah.
sign? Yeah.
So this was a tumor within the extensor digitorum muscle in the leg. And I really couldn't demonstrate the entering and the exiting nerve. But then what I noticed was the increased hyperechogenicity, that is the adiposity in the superior and the inferior poles. Now, in the previous cases of nerve tumors that I had scanned before, I really never looked at this particular feature because, I was happy just looking at the exiting and the entering nerve. But when I started reading up, I saw that, the split fat sign was a well-documented feature in MRI papers, but it was not documented as an ultrasound feature. And so it got me thinking, and I later on wrote that paper, did a retrospective analysis, and I'll come to that later. So this tumor on peroperative, it was found to be definitely a nerve tumor from a branch nerve within this muscle. And the histopathological correlation revealed it to be a schwannoma. So another feature that we've got to look for in soft tissue tumors and nerve tumors is the vascularity and the cystic areas. Now, vascularity is more seen in schwannomas, and neurofibromas are relatively more hypovascular. And necrosis can take place due to the cystic areas are mainly seen due to myxoid degeneration, hemorrhage, or necrosis. And these are seen more in long-standing ancient schwannomas. So we can also see echogenic shadowing foci, which are consistent with calcifications, and these are also seen in ancient schwannomas. Another very well-known sign is the target sign. So this is seen both on MRI and ultrasound. It is more seen in localized neurofibromas and rarely in schwannomas. So on ultrasound, it represents a hyperechoic center, which is fibrous tissue, and it is surrounded by a hypoechoic rim due to myxoid tissue. And this is the target sign. But we've got to remember that this is neither very sensitive nor very specific for neurofibromas or benign tumors. So we've spoken about the well-known features of nerve tumors, which have been documented also in this consensus statement by John Jacobson and team. So just a quick recap. The typical features of a benign PNSTs, as described by them, is a hypoechoic tumor, which is round or ovoid hypoechoic mass. There is nerve continuity. There is increased posterior through transmission. There is internal vascularity. And of course, there is severe pain with biopsy. And he has also described some atypical features, like there is no detectable nerve continuity. It can be heterogeneous. It can be quite large. There might be ill-defined margins. It might show central necrosis or a rapid growth. And the recommendations were that in such cases of atypical findings, we've got to do a contrast-enhanced MRI and also go for a surgical consultation. So other recent papers have also described other features like, while we are differentiating between neurofibromas and schwannomas, is that we can also look at the maximum to minimum diameter, where the neurofibromas being fusiform has a ratio of greater than 3. And more fusiform tumors go more in favor of neurofibromas, especially if they are lobulated. Schwannomas have a more complete encapsulation cystic changes and vascularity and calcifications are seen more on Schwannoma before is that whenever the tumor is central, it goes more in favor of neurofibroma, and when it is eccentric, it goes more in favor of schwannoma. And there is another point which has been mentioned in this paper is that we can look at the nerve tumor transition, which is more infiltrative in case of neurofibromas, and it is more clear and well-defined in case of schwannomas, and it is better delineated in case of schwannomas. So we've got to remember these points and try and differentiate between a schwannoma and a neurofibroma. So coming to the split fat sign, which I spoke about before. So this is basically the hyperechogenicity around the PNSTs, which are intermuscular and intramuscular in location. So when I first saw this particular tumor where I couldn't see the entering a split fat sign, and later on it was proven to be previous cases, and I realized that all of these cases which I had reported as PNSTs had adiposity in the superior and the inferior poles and the split fats, and each of these tumors were basically intermuscular in location or intramuscular, as in this case. This was by Alberto Tagliaco, where they have said that the split fat sign is essentially an MRI sign, but it is also seen on ultrasound, and it is more common in PNSTs and large nerves. But in the paper that we wrote, and in my case, it is seen that the split fat sign was also seen arising to be present in tumors arising from very small nerves. So this was the paper that we wrote on over 13 cases, and I would like to thank Nidhi Bhatnagar ma'am and Dr. Fernando for helping me do this. So something about the split fat sign. It is a known MRI feature of benign intermuscular and intramuscular PNSTs, but it is not specific. It represents a deposition of fat, which is seen adjacent to the proximal and distal ends of a lesion in case of MRI. And on ultrasound, it is seen as hyperechogenicity in the superior and the inferior poles. And it is due to remodeling of fat around the neuromuscular bundle as the tumor grows in the intermuscular space very slowly. So this split fat sign is not seen in malignant PNSTs. And a review of literature, has revealed that the cause of fat in intramuscular PNSTs is still unclear. And they are reported more in benign tumors, and but it is also important that they are not seen in cutaneous or subcutaneous lesions. And I shall show cases regarding that. And it is also not seen in malignant PNSTs. So as a brief recap, the main ultrasound features that has been known for quite some shape, that is the oval, fusiform, round, the ecotech, increased more towards schwannomas, the target sign in neurofibromas, severe pain on biopsies, and more recently, signs such as the nerve transition, then the split fat sign, and also atrophy of the innervated muscles have been described. So this is just one case which I've just given in this slide just to show all the features of a schwannoma. So this is the entering and the exiting nerve. This is the increased adiposity in the superior and the inferior pole, that is the split fat sign. And there was intense vascularity, small cystic areas, which went more in favor of schwannoma, but I really couldn't get a biopsy from this case, but definitely this was a benign PNSTs based on the ultrasound findings. So it's very important to document the origin of these tumors. So tracing it from a known topographic landmark like the Guyon's Canal, I could find out that this was a tumor arising from the ulnar nerve in the lower forearm. So finally, coming to neurofibromatosis or the neurocutaneous syndromes. So neurofibromatosis is also known as von Reckling-Hossens disease, which was first described in 1882 by Sir von Reckling-Hossens. And there are various diagnostic criteria for this syndrome. Cafe or light spots, neurofibromas, that is the cutaneous or localized or diffuse forms, skin-fold freckling, optic gliomers, leash nodules, sphenoid wing dysplasia, or the presence in a first-degree relative. So as mentioned before, the neurofibromas it can be localized, diffuse, or plexiform. So this was a case of a localized neurofibromatosis. Now, the localized neurofibromas can be single or they can be multiple, but they are discrete. So this was a 45 years male where these small nodules were present on his skin since childhood. So we can see fusiform shaped and oval lesions. The target sign was seen in few of them, and they were within the skin. So if we look at it, we see that, as mentioned before, whenever we see nerve tumors in the cutaneous region, the split fat sign is not visible. Another patient with multiple cal spots, and there were small bumps in her trochanteric region. And so on ultrasound, we see that they were the typical cutaneous neurofibromas, discrete, and hence they were the localized variety. But this was a very interesting case which I came across. This is these were present, the coffee OLED spots were present, and they were coming up especially in the suprascapular region. And so we see this big mass-like region in the nape of the neck. I knew that it was a neurocutaneous syndrome, but the appearance was like something which I've never seen before. So you can see that there is thickening of the skin and subcutaneous tissue with a reticular hypoechoic pattern. There was no discrete definite mass. Hyperemia was present, and the ultrasound features were consistent with a diffuse neurofibroma. A CT scan was also done to look at the involvement of any underlying bone. And finally, the tumor was excised, and it turned out to be consistent with a neurofibroma. So I don't have a case of plexiform neurofibromas, and I borrowed this from Dr. Mohit. So plexiform neurofibromas are diffuse enlargement of large segments of nerves, which are present as a discrete lobulated masses, or they can give lobulated neural enlargements with a bag of worm appearance. So it is very important to remember that neurofibromatosis type 1 has a 8 to 13% lifetime risk of developing malignant PNSTs. And out of them, the plexiform neurofibromas are the ones which usually undergo malignant transformation, and the localized and the diffuse variety rarely progress to malignancy. So malignant PNSTs can arise de novo or from pre-existing tumors like neurofibromas or schwannomas, and they are mostly seen in the plexiform variety, as I mentioned before. Typically seen in young adults, there is no gender predilection, more in large nerves along extremities. So when do we suspect that it is a malignant PNSTs? Whenever it is of a very large size, especially greater than 5 centimeters, there is a suddenly and rapidly increasing nodule. The mass has got irregular borders, which are not very well defined. There is local infiltration into surrounding tissues, and the mass is more heterogeneous, and there is a rapid interval growth. But I really don't have a case of malignant PNSTs to show. So there is a genetic background in these cases, and there is a significant recurrent risk and a risk for metastasis, and hence the prognosis is quite poor. So we are done with the PNSTs, and now I'll just go speak on something about the traumatic neuromas. So traumatic neuromas are just mimics of PNSTs, and they are pseudotumors. So they are non-neoplastic disorganized proliferation of the nerve in response to injury or disruption. So there are two types: the stump or the endon neuromas and neuroma in continuity. They're present maybe 1 month to 12 months after an injury, and they're usually present with pain and the Tinel sign at the site of injury. So, and another very diagnostic feature is that whenever you inject LA in this region, there is a temporary relief. So whenever there is a trauma to a nerve and there is a section, when there's a transaction of the nerve, regeneration takes place. And we have to remember that injured and degenerated nerve fibers can regenerate. But the important point for this is that, the gap has to be less than 3 mm, and then they have to be aligned in the same line. So this regeneration usually starts by the 4th day after injury, and it is effective after 30 days and completed in 80 days. So whenever a nerve is transacted and the gap is less than 3 mm and the cut ends are in the same line, so there is something called the Wallerian degeneration which takes place in the distal segment of the cut nerve. That is, the axon becomes fragmented at the injury site. The macrophages clean out the dead axons distal to the injury, and then from the proximal segment, the axons and sprouts or filaments grow through a regeneration tube which is formed by the Schwann cells, and finally the axon regenerates and a new myelin sheet forms. And this is the normal myelination and repair which takes place, and this is completed in 1 year. Now, what happens when the gap is more than 3 mm or the segments are not cut in the same line? Then there is disorganized sprouting from the proximal axon terminals, and these axon terminals do not reach up to the distal fragment, especially when the gap is more. And because of that, the tumors form. The disorganized proliferation of neural tissue will give rise to tumors at the ends of the transacted nerve. So we know that the nerve injuries can be classified into the Sedon's type, which is neuropraxia, exonotemesis, and neurotemesis, and where Sunderland had expanded this classification into 5 types. And we've got to remember that the nerve in continuity, the neuroma in continuity occurs in the Sunderland's type 4, and the stump neuromas or the end-on bulb neuromas occur in Sunderland's type 5 neurotemesis. There's another degree which was added by Mackinnon and Dello, and that is the 6th degree, where there is heterogeneous lesions along the same nerve. So the Sedon's classification, it is just neuropraxia, exonotemesis, and neurotemesis. So neurotemesis is a total transaction of the nerve. But in case of Sunderland, in the case of Sunderland classification, neuropraxia is 1st degree, yes, but exonotemesis has been further expanded into 3 more degrees. That is, when the axon is severed and the endoneuron is intact, we have the 2nd degree of continuity of axons, the perineurium and the fasciculi, but the epineurum is intact. It is the 4th degree. And the neuroma in continuity basically forms in the 4th degree nerve trauma. And of course, neurotemesis is the same for both. There is a complete physiologic disruption of the entire nerve trunk. And this is the 5th degree where we have the formation of these stump neuromas. Then, of course, there is a Sunderland 6th degree, which are heterogenic lesions, where different nerve segments and ultrasound images may show different grades of damage in one nerve. So, as you know, in imaging, high-resolution ultrasound and MRI are the main imaging modalities. And it has again been found in this paper that ultrasound has a higher sensitivity in evaluation of nerve trauma compared to MRI. So neuroma in continuity occurs in the Sunderland's grade 4, where the epineurum is intact, but the rest of the nerve components are disrupted. So there is no gap, but there is a lot of intraneural damage, which forms a wall of fibrosis through which the axons cannot grow. So, there is just a focal hypoechoic fusiform or disorganized mass at this site, at the site of injury. And then there is an entry and an exiting nerve. So there is no gap in the nerve, but there is a disorganized mass, and this is nothing but a neuroma in continuity. There is a loss of the normal nerve architecture and a disruption of the fascicular pattern. So this is a very high-grade injury, and the recovery is poor to none. So this was a case of a 29-year-old male with a cut injury in the right forearm a year back. And then he came with clawing of the 4th and the 5th digits. So on ultrasound, we saw that, at the site of the scar, there was this mass which had this anterior, which had this entry and the exiting nerve. And it was just at the site of the arcuate ligament. In fact, it was a mass in continuity with the ulnar nerve. And this was diagnosed as a neuroma in continuity of the ulnar nerve, which was a post-traumatic tumor. The patient was operated, and later, 3 months later, he, there was good return of function. Neurotemesis is Sunderland's grade 3, where there is a transaction of the nerve with loss of nerve continuity. So whenever there is loss of nerve continuity and there is a gap of more than 3 mm, and, even if they are cut in the same line, there is a disorganized proliferations. These proximal axons cannot reach up and, to the distal segment, and hence there is a formation of tumors because these proximal and the distal ends have no guide rail for regrowth, and these axons sprout in a disorganized manner and give rise to stump neuromas. So it is said that in case of transaction of nerves, surgery in order to prevent the formation of these tumors. So this was a case of a fracture both bones forearm 1 year back, and there's been clawing of the fourth and the fifth finger along with atrophy of the hypothenar muscles. So on ultrasound, we see these hypoechoic bulbous muscles in continuity with the ulnar nerve, and there was a gap in this nerve. So we see it in the long axis and the short axis. There was some amount of vascularity. We could see the scar tissue over here, and on operation, this was what the stump neuromas look like. So this paper published in the Radiographics have said that Sunderland's grade 4 and grade 5 are high degree nerve trauma cases, and hence they always require surgical repair. Whereas the other three, we can always go for conservative non-surgical treatment. So finally, coming to tumors of non-neural origin. So today I shall just be talking about intraneural hemangiomas and fibrolipomatous hemangiomas, and I have borrowed Dr. Ankit's case on intraneural ganglia. So intraneural hemangiomas, these are very rare benign mesodermal tumors. And as an isolated finding, these rare lesions may involve various peripheral nerves, most commonly the median nerve. And tibial nerve hemangiomas, even as isolated cases, are extremely rare. But in my case, I've come across 2 cases where I've seen hemangiomas within the nerve found in association with Klippel-Trenaunay syndrome. There are no reported literature on this. So this was a case of an 11-year-old girl which came with a hemihypertrophy of the. So this was a case of an 11-year-old girl which came with hemihypertrophy of the leg, and then I saw the tibial nerve swollen with small nerve fascicles within them, and with a lot of adiposity around, and this was reported as an intraneural hemangioma. So the main findings of an intraneural hemangioma as per literature is that it is a markedly swollen nerve. There are intraneural anechoic spaces which separate the nerve fascicles oriented along the nerve, long axis of the nerve. This was case 1. And then there was another case where, which I saw it in the medial and the lateral plantar nerves. And so intraneural hemangiomas also demonstrate vascular channels inside the nerve, and it can show a slow blood flow within them, and the venous waveforms are basically predominant. But a very important sign which I found is, again, the increased adiposity, which was seen to surround the intraneural hemangiomas. So again, with the encouragement of Nidhi ma'am, Dr. Mohit and Fernando, we reported this never before reported case, that is the intraneural hemangioma in Klippel-Trenaunay syndrome, the role of musculoskeletal ultrasound in the diagnosis. So Klippel-Trenaunay syndrome is characterized by the classical triad of multiple cutaneous capillary hemangiomas or port wine stains. There might be bony or soft tissue hypertrophy of an extremely localized, of an extremity, which is also known as localized gigantism, and there might be varicose veins or venous malformations. Excuse me. The diagnosis of Klippel-Trenaunay is usually made when any of the 2-3 features are present. So just a moment. So currently the standard for evaluating soft tissue and intraneural hemangiomas is MRI, but in our case, we could diagnose intraneural hemangiomas for ultrasound, and hence it can be quite useful for detection and assessing size and location, provide real-time dynamic information on the tumor's vascularity, and also look at the relation to surrounding soft tissue structures. So I've already described this first case that I saw, the intraneural hemangioma of the posterior tibial nerve, and we can see this fascicles, the fascicles interspersed with this venous linear anechoic channels, which on color Doppler was seen as venous channels. And we can also see that there is a transition from normal to abnormal caliber. We can see this nerve slowly increasing in size, and this is the posterior tibial nerve. So venous channels, I mean, there is vascularity within this, the vascularity was noted within this nerve, and then there were also a presence of other hemangiomas in the subcutaneous tissue, and also within the muscle, that is, this was the flexor hallucis longus muscle, where we saw an intramuscular hemangioma, and MRI proved the presence of the intraneural hemangioma. So just 6 months after diagnosing this case and writing it, I came across another girl, which was again a young girl who has been having swelling of a medial ankle since 6 years, and MRI done elsewhere had just, described it as having, neuropathic changes and soft tissue edema, soft tissue swelling, but they did not really report the presence of nerve hemangiomas. But I saw the large amount of adiposity in the tarsal tunnel, especially, and my knowledge about the previous intraneural hemangioma case, and I knew that this was a Klippel-Trenaunay-Weber syndrome. And so I specifically looked for intraneural hemangiomas, and lo and behold, there were these hemangiomas within the posterior tibial nerve, extending to the medial and the lateral plantar nerves. So we can see these vascular channels inside the PTN, and also the abnormal vessels inside in the tarsal tunnel within the nerve. And also another very important feature that was documented even in the previous case as well as this case was the significant amount of adiposity which was seen surrounding these hemangiomas. So this is just a video of the same. So this is the tarsal tunnel. And so on the long axis, we can see that the tibial nerve is enlarged, swollen with this anechoic channels, and the medial and the lateral plantar nerves were also involved. So the last case is fibrolipomatous hamartomas. These are benign tumors, which is most commonly seen in the median nerve. So these are this was a case of a 10-year-old boy who came with a palpable swelling in the ventral aspect of the distal forearm. And on ultrasound, we see that the median nerve is enlarged, and there is hyperechoic lipomatous tissue interdigitating between the prominent fascicles. And this was diagnosed as a fibrolipomatous hematoma of the median nerve. And as always, we have to compare with the normal median nerve on the opposite side. So I really don't have an intraneural ganglia to show, and I thank Dr. Ankit for giving me this beautiful case. So this was a case of a ganglia of the common peroneal nerve, where we see the cystic mass within the common peroneal nerve, better seen on the long axis, and also diagnosed in an MRI. And this was a case of an intraneural ganglion within the common peroneal nerve, which was later on treated by doing neurolysis on surgery. So the take-home messages are that the high-resolution ultrasound can be used as a first-line imaging modality in the evaluation of nerve tumors. We have to know the topographic anatomy of the nerves, choose the transducers and the frequencies well, scan the nerves in the long and the short axis. But we've got to remember that be it a PNSTS or be it a traumatic neuroma or even a non-neural tumor like a hemangioma or a ganglion or a fibrolipomatous hamartoma, in order to say that this is a nerve tumor, we have to demonstrate the nerve in continuity. But then, as I said, nerve in continuity can be seen only in 90% of cases. In small tumors, we might not be able to demonstrate it. And then we can take the help of other features like the split fat sign or maybe, the target sign, which can help us reach a definitive diagnosis. So thank you so much for your patient hearing, and thank you.
Great presentation as always, JEENA. Very exhaustive, fantastic cases. Absolutely an amazing presentation. I think we have Isha now waiting, so we can combine our questions at the end of both the presentations. So Isha, we are ready whenever you are ready. And just to introduce Isha NARULA, I see her as a very typical sartorius, gracilis, and semitendinosus. Isha NARULA, Arjun NARULA, Napur NARULA have been the stars for MUS 2022. So Isha is the lady of the house, and I believe that out of all three of them, she was the one who performed the best. And Isha, I hope you let the boys not live and you tell them every day about this.
Yes, I do that
Yeah,
very
and these are very academically oriented radiologists who have done wonderful at NARULA Diagnostics. They have now one coming up at Gurgaon also. Isha, would you like to just say a few things about yourself? Where did you do your graduation, post-graduation from? And how did you develop your interest in MSK ultrasound?
Sure, ma'am. I did my graduation and post-graduation both from Lady Hardinge Medical College, New Delhi. And then I did my senior residency from AIMS, New Delhi. And then I got married and shifted to Rohtak, where we have our own center by the name of NARULA Diagnostic Center. So post 2 years of my marriage, I just came to know about this MUSOC conference which was going on in Delhi. And me and my husband happened to attend that conference. And we were like so much impressed by Dr. Nidhi Bhatnagar.
Oh,
yes, ma'am. You were like everywhere. I still remember, I mean, the draped in sari, the way you danced, you were looking like a diva in that conference.
yeah, I got that. Now I think you're ready for your presentation. Okay.
So
Look
you were the
forward.
guiding light for MSK ultrasound, raised for igniting my interest in MSK ultrasound.
I'm honored. Isha, the
Thank
floor
you,
is
ma'am.
yours. Go on.
So I'll share my screen, ma'am. Ma'am, can you see the screen?
Absolutely, and we
Is
can
my
hear you loud and clear. Go on.
So after a wonderful presentation by Dr. JEENA and an exhaustive one on the peripheral nerve sheath tumors, I'll be discussing a case similar to that, and it is a atypical presentation of ulnar neuropathy. So a 63-year-old male presented to us with a complaint of swelling in the right axilla since 4 months. Now this is the spot image of that swelling. Any guesses what it can be based on the age and the area of the swelling? So the first clue that comes to the mind is that it is an axillary lymph node, and based on the age, it can either be metastatic or it can be tubercular. The patient had no other complaint apart from the swelling since 4 months. There was no history of fever. There was no history of weight loss, no history of any cough, swelling elsewhere in the body, just that there was a swelling since 4 months. This was also painless for the past 3 months, and for the last 1 week, there was slight pain in the swelling. So considering that he presented to us after 4 months, we asked for the background history, and the patient told us that he had got an ultrasound and an FNAC done before. And as I told that based on the imaging based on this spot image, our differential would be a lymph node. So the patient ultrasound report, which was done 3 months back, showed right axillary lymphadenopathy. The patient subsequently went FNAC for the same, and it was diagnosed as a caseating granuloma, based on which patient was started on anti-tubercular treatment. But to the clinician's surprise, after even starting of the anti-tubercular treatment, the patient did not respond to it. There was no reduction in the size of the swelling after 3 months of ATT. So the next thing which came to clinician mind was either that they're missing onto something. It may not be tubercular and might be something else, but the patient had no other complaint. Rest all the workup was negative for any tubercular etiology or for any mitotic etiology. So the clinician wanted to go for a but the patient was not willing for the excision biopsy. The patient wanted a repeat sampling of the lesion just before undergoing any surgery. So the patient came to us with this history, and the moment we put the probe for the FNAC, described in her presentation that there was a fusiform swelling in the right axilla with a tail sign. It had a entry, the entry point and an exiting nerve. And so the first thing that came to the mind was that it is a peripheral nerve sheath tumor. It significant vascularity on color Doppler. It was fusiform in shape, hypoechoic with few cystic areas within, classical tail sign. So it was an intraneural origin. So I traced the lesion cranially and caudally to document whether it is intraneural or not. And as we can see in this video, that the both sides, that is cranially and caudally. When I traced the lesion distally, it appeared to continue into the ulnar nerve. So then we proceeded for the FNAC of the patient, as the patient had come to us for the FNAC of the lesion. So usually me and Dr. Apur, so we started on with the procedure. The patient had no symptoms relating to the ulnar nerve prior to this. The moment we started the procedure and put the pressure on the lesion, the patient experienced a pain radiating along the ulnar nerve. That is the Tinel sign. So again, we were like sure that it is a nerve sheath tumor, neuroma, and excited. But to our surprise, the FNAC again turned out to be showed granulomatous cells with areas of necrosis and epithelioid cells suggestive of tubercular etiology. So 2 times the lesion, the FNAC report shows the diagnosis of tubercular, and hence we made a diagnosis of ulnar nerve tuberculoma rather than a peripheral nerve schwannoma or a neurofibroma. And when we reviewed the literature, we saw that ulnar nerve, the peripheral nerve sheath tuberculomas are very rare. And usually in most of the cases, as seen in our case, the primary focus is not detectable either by radiology or by other methods. And patients with these ulnar nerve tuberculomas, they show no typical symptoms of tuberculosis. Our patient also had no symptoms of tuberculosis. He had no symptoms relating to the nerve also, except for the fact that the Tinel sign was positive. And so the importance of diagnosing ulnar nerve tuberculoma is that ultimately the patient has to be given ATT. But if the lesion is involving more than 50% of the diameter of the nerve, then the primary treatment is surgical excision of the lesion, followed by the antitubercular therapy. Earlier, the patient was directly put on to the antitubercular therapy, considering that it was an enlarged axillary lymph node. So just a brief some review about the ulnar nerve anatomy. The ulnar nerve originates from the C8 and T1 nerve roots of the brachial plexus, from the medial cord of the brachial plexus. And as it goes into the axilla, it passes posterior to the brachial artery, and median nerve is seen anteriorly. As we go further caudally, we can see that it is superficial to the brachial artery. Now, this is an image showing the ulnar nerve in the proximal asperi as compared to the upcoming. And distally, as it goes distally, it passes through the arcade of Struder, which is a connective tissue band which joins the triceps muscles and the medial intermuscular septum. So the nerve pierces the medial intermuscular septum, goes posteriorly into the cubital tunnel between the medial epicondyle of the humerus and the olecranon process. These are the two imaging, the two sections which describes that the nerve is piercing the medial intermuscular septum and then becomes posterior. So whenever we start tracing ulnar nerve, as we all know, any area, whenever we are starting tracing, we have to look for the bony acoustic landmark. So for starting of the ulnar nerve, the two bony acoustic landmark which we look at is the medial epicondyle of the humerus and the olecranon process. We apply a lot of gel between these two bony prominences and put a probe in between them, as is shown in the position. And we can see the hypoechoic nerve with the echogenic fascicles adjacent to the medial epicondyle of the humerus. Then we start tracing the nerve cranially. And this is how we trace the nerve cranially. We make this is the position in which we do the ulnar nerve scanning, starting from the elbow. And we progress cranially along the medial aspect of the arm going cranially, tracing the nerve. My pointer is, yes, it is here. Can you see? So this is the ulnar nerve, which we are tracing as we are going cranially till the level of the axilla. This is the axial nerve superficial to the triceps muscle. And then it is coming, as we go cranially, it is approaching the brachial artery. This is the brachial artery. This is the ulnar nerve. So the ulnar nerve is present posterior to the brachial artery. So this is how it was a rare case of the ulnar nerve tuberculoma, which was mimicking as a axillary lymph node. Thank you.
Fantastic. Really, Isha, very unusual. Yes, of course. We've all heard about it. We've read about it time and again. But yeah, it was good to see one. Awesome. It was very nice. So I think I'm going to open the discussions now. May I have both the speakers please put on their videos and their mics. And I'm going to draw Dr. Bipin Shah, sir, Dr.
Yeah.
Ketkar, Dr. Upasana, Dr. Ankit. Could you all, Dr. Fernando, if you're online, would love to have you as a panelist for the questions. And all the delegates, thank you so much for joining us. Even though it's a weekday, you are free to put your videos on and your mics on, and you're free to ask questions to the speakers. Sir, I will invite you to initiate the first of the discussions. Isha, can we have your slides, please, removed from the screen?
Stop sharing, ma'am.
Yeah.
Okay, all right. It's actually,
It's still
is everybody seeing Isha's slides or it's only
Yeah.
Yes, yes, it's there.
where?
I think she has to stop share or
It's just giving me, okay. Is it fine now?
I
Yes,
love it.
yes.
I love it. Thank you so much. Right, okay. So,
So-
sir,
Yeah. So first of all, congratulations, JEENA and Isha, for excellent presentation. You know, both of you very well. And Isha, your case was really interesting. It was atypical. And of course, JEENA's presentation was excellent. Exhaustive presentation on the peripheral nerve sheath tube. You showed a case of a intraneural hemangioma.
Yes.
Can you get similar picture in the infective pathologies like tuberculosis and the leprosies, you know? So I just wanted to ask, or are there any differences between the internal vascularity tumor versus the infective and infective pathology?
These we see them very long linear vascular channels which involve long segments of the nerve, and they are more continuous, these vascular channel vesicles. And then there is vascularity, and this is more of a venous type. And sometimes it's said that these vessels, they can be compressible also. That is what the literature says. But I'm sure that even in case of infective form vascularity, but will it be as linear or as and another not only just in intraneural hemangiomas, even in case of intramuscular hemangiomas or even subcutaneous hemangiomas, we'll see that each of these hemangiomas, they elicit a lot of adiposity surrounding the surrounding muscles or the surrounding subcutaneous tissue. So I think that is also one point where we can say that this is a hemangioma.
I tend to agree. The one thing that you said, and it's very well documented, is that they are predominantly venous channels. So if it's going to be infective, the vascularity is going to be more capillary or arterial type. But just to interrupt, sir, I have to ask you this question. When you said that there is a lot of adiposity around an affected nerve, when you take the CSA, do you include that adiposity in the size, or you exclude it? It's not there normally. You don't see it normally. So when that adiposity is seen in an affected nerve, then you include it. But all said and done, I am not too sure, because I've just seen that one part of the affected nerve in a manner such as this. So I don't know how it will pan out in a surgeon. So your thoughts? Upasana, please join in. Dr. Ketkar, your thoughts? Ankit,
Yeah.
wherever you are. अंकित तुम जहां पर
Yes,
हो
yes,
आ जाओ.
yes, ma'am. Yes,
Yeah,
yes, yes, I'm very much there.
Right.
uh,
Yeah, I saw you. But then, of course,
Jeena,
you're busy.
I just wanted to ask, is it
Yes.
safe to put in a needle in the suspected case of intraneural hemangiomas? What is the diagnostic criteria? Histologically, how do you diagnose?
Actually, it is basically there's not been much literature on intraneural hemangiomas, to be very frank. I mean, even when I was writing for this case, they do surgery, but then as they said that it is mainly maybe neurolysis. That is what they said. I mean, it's mainly grafting or something. But I really don't know if we ought to put in a needle into it.
Dr. Chetkar, just a question, quick question. Why would you want to put in a needle?
No, for histological diagnosis.
But if you're seeing the continuity and you're seeing the nerve,
Yeah, I'm also, that question, because these are very painful.
yeah,
And if you
Okay.
put needle, they're likely to, because as such, the tenal signs are also painful. On
Right.
top of that, if you're going to put in a needle, it's going to be more, painful to the patient. And if you have a classical signs, nerves which is
Yeah.
exiting, particularly in the case of ISHA, she had two signs. I thought ISHA's lesion had also the split fat sign.
That's fine, right, sir.
Yes, yes.
So rather than going for an FNSC, because FNSCs are known to be fallacious, sometimes you don't get a proper
Very
diagnosis.
true, very true.
I think the excision biopsy would have been a better, investigation rather than doing an FNSC,
That brings me
So-
to Isha's question. Isha, you said that if the size is greater than 50% of the nerve diameter, then you say that it has to be surgically excised. I am a little skeptical with that statement because there is just nowhere where it says that, how will you know that it's 50% of the nerve diameter? I mean, the proximal and you're just going to, it will always be greater than 50%. When you see a nerve, it will always be at least twice the diameter of
Yes,
the.
ma'am.
There is just no way, otherwise you won't be able to see it, or maybe if you see it, you may just ignore it as just part of, focal thickening there. But how does that work out? More than 50% of the diameter. That is one part which I haven't come across anywhere. But if there is a reference, I would really love to know, because then we can tell our surgeons that they can wait and watch over a neural tumor, which is always symptomatic. Even if it's small, a neural tumor is always symptomatic. And I think the surgical excision is the modality of choice, is the treatment of choice.
Article which I came across, there were very few articles on the management of ulnar nerve tuberculomas. There was only one article which mentioned this line that I told, that if the diameter is more than twice the nerve diameter, and they had not mentioned how do we measure it, where do we measure it.
Okay.
So that.
Okay. So
I just want to ask one question to JEENA.
Yeah.
JEENA described both the nerve hemangioma along with Klippel-Trenaunay syndrome, right?
Yes.
But how would you like to say it is a venous malformation that is involving the nerve instead of hemangioma? Because Klippel-Trenaunay, it must be a part of the same pathology, I think. So in Klippel-Trenaunay, mostly it's a venous malformation. And capillary malformation that can happen, that is very subcutaneous. Right?
That's what I mean. Klippel-Trenaunay is actually, it has got three, that triad, no? That there are varicose veins, venous malformations. Then
That
there
is a venous malformation.
That localized gigantism.
Yeah.
And
So-
then there are these port wine stains.
That is the capillary one. One venous component, one capillary
Yeah.
component, and
So
one.
now it has been seen that, in both the cases of this Klippel-Trenaunay, they were not just, varicose veins, or, they were not just superficial venous malformations, and they were also these malformations involving the within the muscle, that I saw hemangiomas within
Of
the
course,
muscle.
of course. I
Then
got-
there was, so I think this, it was a part of this, the nerve malformation, that is the hemangioma, was also part of these venous malformation, that in Klippel-Trenaunay we have abnormal veins which can involve the different parts of the soft tissue. It can, go
So
into.
it's basically what you said is basically is a venous malformation kind of thing. It's not an hemangioma because there is a
It is a
difference between-
hemangioma because it is within the nerve, no? When
No,
they are
no.
very
I
vascular
think,
channels within the nerve.
JEENA, Upasana, what she's trying to say is
Yes.
about the terminology. Instead
Okay,
of
okay.
saying
I'm
that
just
it's a
telling you that-
hemangioma, because when you say a hemangioma, you're talking about a very regional kind of localization.
Yes.
And what Upasana is saying is that it is a malformation because it's so diffuse. So there is a diffuse pattern to it. And I tend to agree with Upasana.
Yes.
Instead of saying hemangioma, we could always say that there is a whole diffuse malformation of
Yes,
the
that is
vascular tree.
involving the
Yeah,
nerves also.
totally, I agree. I'm going to draw Ankit here. Ankit, that patient that you shared with JEENA, thanks on JEENA's behalf. Once
Yes.
again, are you there? So,
Yes,
like
yes.
when we talk of intraneural ganglions,
Hmm.
was the surgeon able to say? Because it says that it is from the tibiofibular joint. There is a kind
Yes.
of synovial fluid which
Yes.
tracks along the nerve instead of going in the nerve. So was the surgeon
Mhm.
able to confirm that part?
Yes, yes. So, what they do is they have those electrodes with which
Correct.
I think it is shown in the video that, before going in, what they did is they kind of put that electrode and try to stimulate the articular branch. And then there was no muscle twitching which is occurring. But then when
Correct.
he goes to the other motor branch, you see that there's twitching of the tibialis anterior muscle.
Okay.
So that was the articular branch where there was no twitching of the muscle. And when they put that electrode on the motor branch, you see the twitching of the tibialis
Got it.
anterior muscle.
Got it.
So then what they did is they kind of sliced open and they removed the gelatinous fluid. So it doesn't go like. But let me tell you, I have got a 3-year of follow-up. That guy didn't do well. Even after the neurolysis, he didn't do well. His foot drop did not improve.
That is just
So,
the point. Yeah.
so, so some people, ask me that, after this, why didn't you put in the needle yourself, under ultrasound? But let me tell you, all these tumors look really juicy and nice to put. But how do I know that, I'm not injuring a motor fiber? What if after I put in the needle, the
Correct.
patient is going to develop a foot drop? It's not possible. That's why, I would be very skeptical if some surgeon is going to ask me, hey, Ankit, why don't you biopsy that neurofibroma in the
Correct.
common peroneal nerve or the
Absolutely.
ulnar nerve? How do
Yeah.
you know you're not biopsying the motor fiber?
Absolutely. I totally agree because this is actually one of the big negatives of surgical excision or sacrificing. Sacrificing of you never know what kind of neural deficit you leave behind. So it was extremely brave of Apurva and Isha to put that needle in and go 2 times within that. I am surprised that the patient did not kick them because it looked so painful, but then anyway, they got the diagnosis. That is most important part. That's really an important part where, the diagnosis were more important than the part. But that brings me, like you're saying it, Isha, that patient, that 13-year-old girl where you said there's a huge, big, thick growth at the
Yes.
nape of the neck, if it hadn't been for the cafe au lait spots that you got, it actually looked like a very aggressive fibromatosis. I would have actually wanted to put it and see if, because I'm sure that she was not symptomatic, a lesion growing to that an extent and the patient not wanting to do anything about it. So all I'm saying is, do you have a follow-up? Because with aggressive fibromatosis, there is a big overlap. You see, it's one of the differential diagnoses in one of the orthopedic articles and I was very surprised. So when it said about peripheral nerve tumors, it said the neurilemomas and the schwannomas and going to neurofibromas, and then one was desmoid and just kind of stuck there. When you showed that, I thought you were actually showing a desmoid or a fibromatosis, aggressive fibromatosis. And the thing about that is it always recurs and there is an overlap there. So, like if somebody said clear cut that was a plexiform neurofibromatosis, I will not be convinced. I would rather have you go back and see how that little girl is, because if it comes back, she needs to be on the chemotherapy. That's just my submission. It actually looked like desmoid. It actually looked like that aggressive kind of, fibromatosis. So
Remember there was a excision. I mean, after the excision, the
always
histopathology
after the
revealed
excision.
that, yeah.
It's always
Yeah,
after the excision that it reverts. So, and the timeline that is given for a desmoid and an aggressive fibromatosis to come back is about 6 to 8 months. So
Okay.
I would love to have a follow-up if there is a recurrence, because if there is a recurrence, she needs to go on chemo. And nowadays, radiation, chemo, one of the two.
Okay.
Yes, just one more question, Jeena. Does the sclerotherapy works in the intraneural hemangioma? Is there any literature about sclerotherapy being used
No,
or no?
there are no.
None.
Okay.
None. There is no other thing except it says surgical or just follow up. No, nothing. There is no
Okay.
other thing that is there. So, are there any questions? And neither Isha nor you emphasized on the vascularity of peripheral nerve sheath tumors. And everybody, all the articles talk about the vascularity, and they say that, of course, it is not diagnostic of anything, but the nerve sheath tumors do have an internal vascularity, which helps us to become even more confident that we are dealing with, you have the neural continuity and then you have the vascularity. So you didn't find it, or it's just that you thought that we had such diagnostic elements sitting there that
No, ma'am. I had mentioned about looking at the vascularity and the cystic areas. There, I have said that, vascularity is more seen in schwannomas, especially in long-standing ancient schwannomas. And neurofibromas, on the other hand, are more hypovascular. So when we see more of vascularity, it goes more towards schwannomas.
Right. Okay. So I'm going to draw all
Because
the
in all the schwannomas that I have seen, there was vascularity. I mean, there was this ulnar nerve schwannoma, which I saw.
vascularity that we're talking about. I don't know, but you seem to have nice, very convincing kind of vascularity. I did see a couple of them. You had a peripheral, perilesional kind of vascularity, but that intralesional flows that you come across, I just couldn't see that. So I was kind of wondering whether in your study you did find vascularity, or it was just a coincidence that you thought that that we could just go on with the grayscale studies. I am inviting everybody. Any more questions, or we
So I
should?
have I have one question for Dr.
Yeah.
JEENA. You've seen so many cases of peripheral nerve sheath tumors. Have you had an opportunity to, or even a request to biopsy them percutaneously, or were they all kind of operated for
They were all,
intraoperative?
they were all done, like, not all of them went for operation, like this posterior tibial, the one in the knee. I couldn't get a follow-up for that, but these small ones, and few of them, they were basically operated. I mean, they don't ask for biopsies mainly because they think that it is very painful.
Yeah.
And
So I agree with you, because I think that's the same thing what we have in our experience. So with your also, they don't ask for too many biopsies, or almost no biopsies.
Almost
I have
They
not
will
done
they
personally.
will go in and they will kind of just remove it, because in fact they will call in a plastic surgeon, and just to make sure doubly that they're not if it's a main nerve trunk like the ulnar nerve or the common peroneal nerve, they're not damaging the motor nerve fibers.
No, to bring back to you, Ankit, I think instead of putting in a needle or doing anything else, altu faltu, believe me, Tidal sign is just one of the most perfect clinical signs. And even with the deep tumors, you can elicit it so beautifully, because there is that nerve radiation and that pain that shoots it, and the patient just says, so that really helps to put all your ultrasound findings and your clinical tunnel. And then I don't think that anybody would want to really put in a needle for a diagnostic purpose. Then, of course, yeah, excision is, of course, the modality.
Ma'am, but in the hemangiomas that I saw, the nerve hemangiomas, they did not, really complain of that Tinel sign, or, maybe I didn't elicit it properly, but the symptoms were not, so much like of a nerve tumor. Whereas in the others, even the small schwannoma, you just tap it and, the pain shoots. But in case of the hemangiomas, maybe it was the more of that surrounding fat or that adiposity, which was, not really
And you have a
stimulating
point
the
there.
nerve.
You have a point there. And I think we will be more mindful next time we come across something like this. We would want to really cross-check whether it works there or not. And if it is not working, then why? It would be a great thing to find out. It would be a great thing. So like we are already going on 9:45 and literally 10. And I will take this opportunity to sum up what we have learned today. The first and the foremost, I think everyone would be so happy the way JEENA taught the anatomy of the nerve. You always forever forget, where is the perineurium, where is the endoneurium, what do you mean by fascicle, where does something come from? So thank you, JEENA, for including that in your presentation, because it really helps to understand the concept of the origin of a certain thing. The second thing, of course, that I am going to emphasize and re-emphasize, despite what we have gained today, that it is absolutely not mandatory, and it is really not possible. Various studies have said that you will be on ultrasound, be able to differentiate ultrasound sonoscience between neurofibroma, schwannoma, or even malignant PNSTS. So let's not go that way and make an effort to give a histologic diagnosis saying a peripheral nerve sheath tumor would be enough for us, and where is it coming from, if at all possible. 4 signs, very important signs. One is the hypoechogenicity of the tumor. The second is the homogeneity of the tumor. The third very important sign is posterior enhancement, because they are so homogeneous. A posterior enhancement, so much so that sometimes a peripheral nerve sheath tumor can almost look like a ganglion. It mimics a ganglion. So that is the point at which you put your vascularity to rule out a ganglion. And you know that you're dealing with a solid tumor. They have mostly all the studies, starting from the AJR to IJRI and multiple studies. So that is where the vascularity comes. Do not overlook power Doppler study in your suspect peripheral nerve sheath tumors. Last, of course, but not the least, and it cannot be overemphasized, the rat tail sign, or what we call as the nerve continuity, which is extremely important for us to understand the concept of a peripheral nerve sheath tumor. So one thing that I have found useful, if there are multiple nodules, the patient says, I have one here and I have one here, and you know that they are not subcutaneous lipomas, do think terms of neurofibromatosis, or what we call as neurofibromas instead of schwannoma. Schwannomas usually are lone warriors, only one. So if you have one, I think 99% times you can be very sure to tell telephonically schwannoma. And if there is anything else that the faculty would like to add, the senior people would like to add, please go on. Otherwise, we'll close it for the day and look forward to another webinar. Thank you very much.